Sahani and his team of speakers from University of Washington will be taking these sessions for us. So please be there. So let's move on to our prelude sessions for today. The first session will be by Dr. Abhishek Mahajan. He's a consultant radiologist at the Clatterbridge Cancer Center, NHS Foundation Trust, Liverpool, UK. An honorary senior lecturer at the University of Liverpool. He's an ex-professor of radiology and consultant radiologist at Tata Hospital in India. His areas of interest are AI, radiogenomics, and biomarker imaging, neuro, head, neck, and thoracic imaging. He has more than 392 publications, 200 national and international faculty lectures to his credit, associate editor in the Frontiers of Oncology, Frontiers of Nuclear Medicine, Frontiers in Radiology. He is a core member of the Respond Consortium, the BRATS Challenge Consortium, and the FETS Challenge Consortium, a peer review committee member for DBT International EU India Horizon 2020 Challenge. He has received the AI Innovator of the Year Award 2021 by ELETS and IRI and several others. So let's move on to his lecture, which is on MRI of tongue lesions. On to our prelude sessions for today. The first session will be by Dr. Abhishek Mahajan. He's a consultant radiologist at the Clatterbridge Cancer Center, NHS Foundation Trust, Liverpool, UK. An honorary senior lecturer.
Thank you to Dr. Patkar for giving me this opportunity, and I'm very pleased to be on this panel of good radiologists discussing the MR imaging. The topic given to me is imaging of tongue cancer, and this particular presentation would take you through the intricate imaging points which you can actually tell the surgeon before he plans his surgery. The first to begin with, can you see my slides? Is all okay?
Yes, everything is fine.
Okay. So first and foremost, we have to understand that which imaging and why. It's very important that you choose the right imaging modality, and the right imaging modality, I don't think so that any of the radiologists wouldn't agree, is MRI, because MR scores over CT in terms of the contrast which we get in the muscles. Also, that there is very less chances that there is bone involvement. So bone involvement, if at all, if we are suspecting, then we can supplement with CT as a problem-solving tool. So due to the superior soft tissue contrast, which is not seen in the CT, MR definitely is the modality of choice for imaging of the tongue. What all MR would help you into assessing while doing an MR of the tongue, it gives you tumor thickness and depth of invasion. The depth of invasion concept is a very important concept because it is the current AJCC 8th guideline for staging the tumor. If you understand the concept of depth of invasion, then you can adequately stage the tumor. The second is the most important is extension across midline, because if there's an extension across midline, then you would be looking to along the nose, along the contralateral neck. Extension into the muscles of the tongue, the deep extrinsic muscles and the floor of the mouth. Involvement of the adjacent structure, that is the tonsils and the epiglottis and the pre-epiglottis. Invasion of the mandible and invasion of the neurovascular bundle and submandibular canal. So one has to at least report these important features while reporting an MR of a tongue cancer. We'll briefly hit on the anatomy and then we'll move on to the imaging findings. So the tongue is divided into oral and the base tongue. The division is done because the treatment of the oral tongue is different from the treatment of the base tongue. The oral tongue is treated with surgery and the base tongue is treated with chemoradiotherapy. This division is actually done by the circumvallate papillae, which are seen on clinical examination. However, we do not see the circumvallate papillae on the clinical examination. Hence, there is an imaginary line, plane, which is drawn between the junction of the soft palate and the hard palate over here up to the hyoid bone. Anything behind this junction is the base tongue, and anything anterior to is the oral tongue. So once the oral tongue, this particular imaging, the slides would be basically dealing with the oral tongue because that is treated with surgery. Coming to the first and foremost axial section, which you see in the at the level of the tongue, is the fern-shaped pattern with the lingual septum between. This fern-shaped pattern is the intrinsic muscles which are interdigitating with interdigitating fat. This fern-shaped pattern should be considered as the uppermost level of the tongue, and these are the intrinsic muscles. You have the masticator space over here, the mandible, the medial pterygoid, the masseter muscle, the anterior buccal fat over here, triangular buccal fat, and the parotid duct. You have the mandibular cortex, which is hypointense, the alveolar cortex, and you have an important structure over here, that's the buccinator muscle. The moment you go a little bit down, you will again see that the interrogating muscles are prominent and the fat has become more prominent because now the insertion of the extrinsic muscle starts. So this is the section which is an important section to understand the extrinsic muscles. The extrinsic muscles, usually the most important critical point in the extrinsic muscle is the genial tubercle, which is the center point of the mandible. So this is the mandible over here. The center point is the genial tubercle. The genial tubercle gives maximum origins to the muscles. The first and foremost muscle is the geniohyoid muscle. A geniohyoid muscle is an inverted V-shaped muscle which takes origin from the genial tubercle and gets inserted posteriorly. Lateral to the geniohyoid muscle, you will have a fat-containing area, which is the space of the sublingual gland and the sublingual space. Posteriorly, you have an inverted V, which are two muscles. One is the medial one, which is the hyoglossus muscle, and the lateral one, which is the mylohyoid muscle. As we go posteriorly, you have the submandibular glands, which are just appearing, and posteriorly is the lingual tonsil. So the lingual tonsil is also important, that the lingual tonsil enhancement should not be considered as a mass. These are normal enhancing structures in the oral cavity. As we go further down, we have the structures which are the floor of the mouth structures. That is the anterior belly of the digastric, the two symmetrical structures, the submental space over here, the hyoid bone, the submandibular glands, and the pharyngococcygeal muscles. As we go further, we need to see the other muscles, and that is the sagittal plane, which gives the muscle which forms the bulk of the tongue. So the tongue predominantly is formed by the genioglossus muscle. It's a fan-shaped muscle, takes origin from the genial tubercle, forms a fan. You can appreciate the fan over here, and it gets inserted into the intrinsic muscles of the tongue. This particular muscle forms the bulk, and during the glossectomy, genioglossus muscle is the muscle which is predominantly resected. The floor of the mouth is underneath this muscle. There are two muscles which run horizontally from the genial tubercle to the hyoid bone. So this is the hyperintense signal of the marrow of the hyoid bone. This is the mandible, the genial tubercle over here. You see the genial tubercle is giving origin to the first muscle which is getting inserted into the hyoid, and this is the geniohyoid muscle. Inferior to the geniohyoid muscle, there is another linear structure, muscle which is mylohyoid muscle. So this muscle forms the floor of the mouth. Any disease involving the mylohyoid or going beyond that is involvement of floor of mouth. Coming to the coronal anatomy, the coronal anatomy is usually done to see the floor of the mouth and the neurovascular bundle assessment. So the mylohyoid muscle, which forms the floor of the mouth, is a sling-shaped muscle which runs all along. So you can appreciate the sling over here and the hyoid bone in the center. So this is the mylohyoid sling, and you can appreciate the lingual artery flow voids, which demarcates the neurovascular bundle. We'll see the neurovascular bundle in detail. Coming to the another section which is important, this is the lingual septum on the coronal section, which lateral to it is the root of the tongue, which is formed by the genioglossus muscle, that I said is the bulk of the tongue, and then you have the mylohyoid sling, and that inferiorly the anterior belly of the digastric muscles. So the neurovascular bundle is appreciated by the lingual artery, the flow within the lingual artery. We per se do not see the lingual nerve, but we identify the flow all along its course and try to appreciate the neurovascular bundle. How do you identify where is the lingual nerve? The lingual nerve and the hypoglossal nerve lies lateral to the hyoglossus muscle. So the lateral one is the hyoglossus muscle, the lateral one is the lingual nerve, and the hyoglossus muscle to this flow wide. So treatment plans. So stage 1 and stage 2 oral cancers, like the tongue cancers, are treated with single modality, predominantly surgery or radiotherapy. And if it's stage 3 and 4, they are treated with surgery with post-operative radio and chemotherapy. I suggest reading our article on this, which gives a comprehensive review of all the imaging modalities. But per se, I'll be discussing this table in depth. This table helps you into guiding the management. So the first concept is depth. If the depth is more than 10 millimeter, there are poorer outcomes. So it's important to document your depth in the report. Spread across midline, if it is present, it means there are contralateral nodal metastasis, and plan the contralateral neck dissection as well. If there is neurovascular bundle invasion, that means the chances that the patient would need total glossectomy. If there is posterior extension or pre-epiglottic space involvement or hyoid bone involvement, then it is relative contraindication to chemotherapy, surgical management. You give a trial of chemoradiotherapy and see if the tumor is reducing. Posterior spread to the masticator space, which is advanced disease. It's advanced, so it's palliative treatment. And bone erosion, which decides the mandibulectomy, whether it's middle third or the lateral mandibulectomy. So the first concept is tumor thickness and depth of invasion. The two things are different. What we usually used to do in the past was tumor thickness. We used to measure the medial to lateral dimension, and that would be the tumor thickness. However, the newer concept is depth of invasion, which is different, and I'll show the diagrammatic line diagrams on that. So tumor thickness, if it is more than 4 millimeter, there is incidence of neck nodal metastasis, and elective neck dissection is recommended. So it means the tumor, if it is more than 4 millimeter medial to lateral, all patients should undergo elective neck dissection. That's the consensus by the N0 trial performed at Tata Memorial Hospital. So let's understand the tongue tumor and what the tumor thickness and depth of invasion are different. This is an imaginary tumor which has been drawn over here. The tumor can be of three types. It can be exophytic, it can be exoendophytic, or it can be only endophytic. So in the exophytic tumor, you will draw a mucosal plane, which is the boundary of the, let's say this is a tumor over here. So if I draw an imaginary plane for the tongue, so it would run something like this. And this is the exophytic component, and this is the endophytic component. So if you draw the imaginary mucosal plane, medial to lateral is the tumor thickness. Again, if you draw this imaginary plane, excluding the exophytic component, the medial to lateral is the depth of invasion, and the total one would become tumor thickness. In an endophytic tumor, it's very difficult to understand this imaginary plane, and whatever is the level left, enhancing tumor left behind, that forms the depth of invasion. So depth of invasion and tumor thickness are two different concepts, as seen on this case. If I draw a line over here, imaginary plane of the mucosa, outer part will not be included in depth of invasion. If you include the total one, that will become tumor thickness. So coming to the next important criteria, so this tumor is a low volume disease, would be resected with surgery, which could be wide local excision. However, in this kind of a low volume disease, which is at the level of genial tubercle, that means it is involving the most of the origins, this patient would need total glossectomy or gross dissection, total dissection. Because the genioglossus muscle origin itself is involved. Sorry. Hello? Is there any disturbance?
No, sir, you can continue.
So again, as I said, like tumor can be endophytic or it can be exophytic. This is an exophytic tumor. This is the imaginary plane over here. If I consider this as the imaginary plane, this would be the depth of invasion, and the total would be tumor thickness. As the tumor reaches close to the lingual raphe, the disease becomes T4. So remember, when your disease is reaching close to or it's more than 20 millimeter in depth, or it is close to lingual raphe, it is T4 disease. And if there is spread across the midline, start looking for the contralateral node. So this is a disease which is extending across the midline. It has a node on the ipsilateral side and a node on the contralateral 1B side, and then there's a submental node as well. Involvement of neurovascular bundle, as I said, that you have to identify the lingual artery flow void, and lateral to is the lingual nerve and the hypoglossal nerve, which if involved would lead to tongue atrophy, which is indirect sign, which is a late presentation, but early signs such as hyper intensity within the muscles of the tongue could be represented because of the lingual muscle denervation. Lingual nerve denervation. This is contralateral neurovascular bundle involvement, and in such cases, there is need for total glossectomy. So if the single side is involved, partial glossectomy is done, and if both the neurovascular bundles are involved, the patient is a candidate for total glossectomy. Another important feature to identify submandibular space involvement, you have to differentiate submandibular space involvement versus submandibular gland inflammation. The moment there is genial tubercle and the genioglossus muscle involvement, that leads to obstruction of the submandibular duct, which runs between the genioglossus muscle. And this secondary duct obstruction leads to enlargement of the gland, and that should not be confused with submandibular gland involvement. So one has to trace the course of the submandibular duct. If the submandibular duct is not involved and there is direct involvement of the submandibular space, that means it's a true submandibular space involvement. Posterior extension into the vallicula, into the preepiglottic space and tonsil, they are poor prognostic markers, and such are the cases which are candidate for chemoradiotherapy again. Mandibular invasion, as I said, it's only seen in 10% of the cases, and it is definitely seen in advanced cases, but it's not so common to see. Hence, we rarely need CT as a problem-solving tool to identify subtle cortical erosions. So this is a case where the cortex is completely maintained. You can see the hypointense cortex. However, here there's break of the cortex with marrow invasion, and this is showing mandibular invasion. I'll show some case capsules as to how we can plan the management, and I'll discuss the points how to read this particular case. So there is case number 1, and in this particular case, I will start reporting my tongue tumor that there's a right lateral border tongue disease, which is enhancing and shows a hyperintense signal on the T2 weighted images. I'll measure the depth of invasion, and I'll document the depth of invasion in this particular case. So that's approximately 7 millimeter, which will make it a T2 tumor. The disease is far away from the neurovascular bundle. Very unlikely that it would have involved the neurovascular bundle. It's not even close to the lingual raphe, so it's just abutting the hyoglossus muscle. So I would not be worried about the contralateral nodal disease, and by and large there are no particular nodes seen on this particular imaging, and it's showing restricted diffusion. So it's a small volume T2 disease, probably N0, and I would recommend no need for doing a chest CT for this particular patient for workup. In this particular case, there's a large volume disease which is crossing the lingual raphe. There's contralateral spread of the disease. This is definitely a stage T4A disease. There's an ipsilateral enhancing nodes, some break in the cortex with involvement of there's an adentulous socket at the level of the tumor, which is probably there's involvement of the marrow also. And this disease is abutting the anterior cortex with erosions along the anterior cortex as well. The disease has gone close to the genial tubercle with involvement of the genioglossus muscle. The whole fan of the genioglossus muscle is involved. And this patient would be a candidate for total glossectomy. And I would recommend to do an ultrasound of the contralateral side to pick up any nodes which might be missed on the MR. In this particular case, there is definitely a need to do CT thorax to rule out any metastasis in the lung. This is another advanced stage disease presentation. So this is a large volume disease. On the coronals, you can see the neurovascular bundle being involved on the ipsilateral side. The mylohyoid sling over here is also involved. That means the floor of the mouth is involved. And there is direct extension into the submandibular gland. However, you can see the dilated submandibular duct also here, which is involved. The tumor is abutting the lingual raphe, and there is ipsilateral necrotic 1B node. However, there is a contralateral node also, which appears to be indeterminate. I would say it's highly suspicious, and this is the normal submandibular gland. So you can appreciate that the gland on the ipsilateral side is enlarged. The signal of the mylohyoid muscle is lost. Floor of the mouth is involved, and the neurovascular bundle is important. Some bit of change along the cortex is seen. So this case might need a CT to evaluate whether the cortex periosteum is eroded or not. You can see the same thing reaching over here along the alveolus. Going on to the next case, I forgot to tell you one important point in this case. So if you see the axial section, the node is seen over here, which was seen here. And this particular node is necrotic. The planes of the nodes are not very good. So this is a node which has extracapsular spread. And extracapsular spread is again a poor prognostic marker in oral cavity. It directly makes the disease N3. So any node which shows necrosis or shows perinodal standing or has loss of planes with the stap muscles is a N3 node directly. Coming to the next case, this is a large volume disease eroding the mandible with pathological fracture of the mandible. There are necrotic nodes on both the sides, even at the submental level. The whole of the tongue bulk is involved, and posterior extension into the vallicula and the posterior pharyngeal wall with extensive large necrotic nodal mass at level 3. This is a gross disease. Patient is a palliative candidate, and he would only receive palliative therapy for the symptomatology. Let's look at the post-therapy imaging. Post-therapy imaging, we in our center now follow NIRADS categories. It's beyond the purview of this particular presentation, but for the sake of just to highlight that we report using NIRADS, and NIRADS category 2, which is very important because it's a submucosal disease usually seen in tongue, should be kept in mind. Primary imaging after surgery is done by MRI at 6 months, and if there is a suspicion, you supplement your imaging with PET-CCT. Remember that do not perform PET-CCT in the early 8 to 12 weeks, because there are chances that there will be inflammation and you will get spurious FDG uptake, which can lead to misdiagnosis. So at 8 weeks, doing an MR with diffusion-weighted study is the gold standard of follow-up imaging. And if there's a doubt, then you can supplement with either direct biopsy or a FDG PET-CCT. So this is the recommendations by the NIRADS. If it's NIRADS 1, that means there is no disease, routine follow-up. If it's NIRADS 2, short interval follow-up or PET-CCT or direct inspection. NIRADS category 3 is kind of suspicious, indeterminate, and then you need to do a biopsy. And NIRADS 4 is it's definitely recurrence. And then you plan your recurrent case. Either you do upfront surgery with CT of the thorax, or you plan a FDG PET-CCT to rule out any metastasis and then plan your surgery. And this is an example of NIRADS category 1. In the NIRADS category 1, you see that the normal enhancing palatine tonsil is seen, which should not be considered as an abnormal disease. As I told, no, palatine tonsils enhance normally. There is no mucosal enhancement and there is no abnormal FDG uptake. So this patient is a BOT case which was treated with chemoradiotherapy, and it's NIRADS category 1. Usually after partial resection, you see that there's retraction, there's loss of muscle mass. This is a normal case. After post-surgery, you see that there is loss of the bulk on the operated side, and there's retraction of the tonsillolingual sulcus. This retracted tonsillolingual sulcus may at times enhance and should not be considered as recurrent disease. In total glossectomy, there is reconstructions are performed by either the tram flap or by the pectoralis flap. So you will see that the ipsilateral side pectoralis will be deficient, and you will see the skin and the submucosa. So this usually will have hair also, because this hair might grow if the patient is hairy, and usually the part is taken where there's no hair. And this particular muscle is having subcutaneous fat over here. So this is a normal appearance, the skin and the subcutaneous fat after total glossectomy with reconstruction. And this is an example where there's total glossectomy has been performed, and there is suspicious nodular enhancement, which either is a post-operative edema because the patient received radiotherapy also, and it could be recurrent. So if you perform your diffusion-weighted study sequences, you can very well differentiate that it's a recurrent tumor and not a post-operative edema case. So to conclude, I would say that imaging plays an important role in staging of the tongue cancers. It depicts the depth of invasion, which is otherwise very difficult to measure on clinical examination. Deeper extension, which are usually not visualized on clinically. And it's very important for radiologists to have an effective checklist which is being adhered, and you document the positive and the negative finding so that you don't miss on any of the findings and report adequately. With that, I thank you for your kind attention, and I recommend reading our article.
So that was Dr. Abhishek Mahajan, who spoke on MRI of tongue lesions. So moving on to our next session, we have Dr. Gaurang Shah, who is a clinical professor in radiology, director medical student education in neuroradiology, director clinical functional MR service in the neuroradiology division at the University of Michigan. His special interest in functional MRI and advanced MR applications in neuro. His topic is MRI of cranial nerves.
Thanks a lot. Appreciate the invitation. And I think I'll just start my talk right away. Let me see if I can match it. So if I'm going wrong, just let me know. That.
We can see your screen now. We can see the slide, sir.
Should I share the screen?
Yeah, so it's sharing well.
Should I?
Yes, sir. Where it's written hide.
Okay, so I should click on hide?
Yes, sir.
Okay. And
Done. We can start.
Okay, fantastic. Thank you very much. First of all, I thank Dr. Parker for inviting me onto this great webinar. I'm sure I'm speaking to many old friends and many new friends, but there's no way of knowing for me whether what I'm saying is registering with you. So I hope, I wish this could have been a two-way session, but somehow it is not. But let's look at the cranial nerves, and that's the most interesting topic. There are 12 of them, like a clock, and it's kind of a cranial clock. And in a way, all the cranial nerves can be actually compartmentalized, and they can be segmented into different parts so that we can understand them better. Now, this is from Ari Blitz, a good friend of mine who is now at the Cleveland Clinic. And what he actually has proposed here is the segmenting of the cranial nerves. And this kind of allows us to understand the cranial nerves much better. So first of all, segment A is the nucleus. So that's something which we do not readily identify, but because of our knowledge of anatomy, we can actually know where the nucleus of the cranial nerve is. The second one is the parenchymal fascicular part, which means the white matter fascicles, which actually start off from that nucleus going outside. And that also is within the brainstem predominantly, or brain parenchyma. And we can actually map them out with DTI if we try hard enough, but we do not readily see that. And the third segment, which is C, which is a cisternal segment, is something that we are very intimately familiar with, because that we can see very well getting into the different parts. So from the cisternal segment that it comes out from the surface of the brain, it goes into the dural cave, and the dural cave varies from different cranial nerve to different cranial nerve, but that dural cave again is a very important segment. Let's say for cranial nerve 5, it's Meckel's cave, which is the dural cave. From there, it goes on to an interdural segment, which means that it pierces the dura, the outermost layer of the brain, and then it enters into a foraminal segment, which is the foramina of the skull base, through which it is going to exit the skull and enter the soft tissue of the neck or the skull base, and that is the extraforaminal segment. So if we actually divide the cranial nerve into all these different segments and then analyze it, it is actually much more easy for us to analyze and look at the cranial nerve. Okay, so again, this is a pretty good graphic which actually explains us how this thing works out. So let's say first segment is within the brainstem. This is the fifth cranial nerve, the MR image on the right side, and the CT image on the left side. We are actually looking at the same anatomic plane on both CT and MRI. So this is segment A and B, which is within the brainstem. This is segment C and D, which is actually in the CSF. And this is the cisternal segment of fifth cranial nerve. Let me see, you may not be able to see my... Okay, so this is actually the cisternal segment of fifth cranial nerve. And this is segment D, which is the dural cave segment. This is the Meckel's cave area. And going forward, then actually you enter the foraminal segment. So this one actually outlines the interdural segment in some ways, and then the fifth cranial nerve goes into the cavernous sinus on the lateral margin, and that we would see actually much better as we go ahead. But I'm just outlining the different parts of the cranial nerve. So, and then going forward again is the segment within the bone, which is a foraminal segment. This is foramen rotundum. Seen on MR as well as on CT, and then it actually gets into the pterygopalatine fossa. And that is the extraforaminal segment that I'm talking about. So this is how you kind of divide the different parts of the cranial nerve, and this is how you would like to see it. So let's start off with the first cranial nerve, which is actually not a cranial nerve. It's more or less, in my view, it's not a cranial nerve. It's an extension of the brain. To call it a cranial nerve is fake news, as somebody would say. But at the same time, it has been called a nerve for a long time. So let's kind of look at it and look at the CT anatomy and the MR anatomy. So this is crista galli in the axial plane of the CT, and this is the coronal plane of the CT. And the midline is the crista galli. At the bottom are actually the cribriform plate. This is the lateral lamella, the vertical segment of the bone. And here is the foveate modalis. And on top of that, there is CSF. And as you can see very well, and you will see it much better on the the coronal MRI weighted images, is that there is actually just above the cribriform plate, there is a pool of CSF, and that is known as olfactory sulcus. And that olfactory groove, which actually communicates with olfactory sulcus, contains the olfactory nerves. And that is something you will see it very well here. So these are the olfactory bulbs, and these olfactory bulbs actually are forming from here. So if you see here at this picture, this is the olfactory bulb, that's olfactory nerve. These are the different branches of the olfactory nerve from the vault of the nasal cavity, and they all kind of communicate and make this thick stalk of the olfactory tract. And this is what we see here. This is the olfactory tract here, and this is olfactory sulcus in which it is lying. Medial to it is the gyrus rectus. And then this olfactory tract will lead it to an area which is known as the olfactory trigon. Now, most of the fibers of the olfactory nerve actually turn laterally, and they communicate with the amygdala. And that explains the fact that sometimes we have very visceral reaction to some kind of smell, because amygdala is the seat of flight and fright. And if we do not like certain smell, we don't even think about it, but we recoil and we just want to move away. That's part of our reptilian brain, which is connected with the hippocampal system. And the olfactory nerve communicates directly with the amygdala through its lateral fibers. And that is why it kind of explains a lot of things. And again, you have the middle stria and intermediate stria, and then it communicates with the olfactory nerve on the other side. So looking at some of the pathology, this is one of the most well-known pathology of the olfactory nerve, which is the esthesioneuroblastoma. You can see it on CT as mildly hyperdense lesion, on MRI as intensely enhancing mass, which actually is contiguous across the cribriform plate. There's a big part within the nasal cavity, and across the cribriform plate, you can see an extension of that mass getting into the brain. But between the mass and the brain, there will be a cystic cavity here. And that actually is very pathognomic of the esthesioneuroblastoma right here. Here is a case of 46-year-old male with a head trauma, and you can see that this is a sequela of that, where the gyrus rectus is affected. The olfactory nerve is not very well seen, and it's not a surprise that he had anosmia. Kallmann syndrome, it's a very rare genetic disorder, and you can see that there's congenital absence of the olfactory nerve. So this is normal anatomy, and as I showed you earlier, this is the olfactory groove, this is olfactory sulcus, this is a gyrus rectus. These two are the olfactory nerves, and this is normal anatomy, but in patients with Kallmann syndrome, there is congenital absence of the olfactory nerves. And again, there is a condition called uncinate fits, and that's a seizure-like activity which takes place in the lateral olfactory area. This can produce the hallucination of taste and odor. So now we move on to the second cranial nerve, which again is fake news that it's a cranial nerve. It's an extension of the brain. As you very well know, you cannot have any neurofibroma or schwannoma of the optic nerve because it's not a nerve, it's more or less an extension of the brain. If you look at the different segments of the optic nerve, It starts off with a small intraocular segment. It's pretty tiny, like a 1 millimeter in the length. And actually, you can see it around the region of sclera. It's known as lamina cribrosa right there. And this is where the ganglion cells would exit the orbital globe. Then there is an intraorbital segment, which is about 2 to 3 centimeters in length. And this is something which is seen within the orbital cavity. It continues on posteriorly to a segment called intracanaliculaar segment, which is about 4 to 9 millimeter, depending on where you are looking at it. So this is a coronal CT and just above the superior orbital fissure. So this is superior orbital fissure. And here is where you will see the optic canal. And up through that canalicular segment, it continues on into the intracranial segment, which is about a centimeter long. And it actually meets with each other at a structure, which we very well know, and an optic chiasm. From optic chiasm, there's decussation of the lateral fibers of the optic nerves, and then it continues on into the optic tract. The optic tract, again, is an X-shaped structure. And from optic tract, again, it continues on to the retrochiasmal structure. So the retrochiasmal structures would be from the optic tract, it will go on to the lateral geniculate. A bulk of it will go to the lateral geniculate body. A bulk will go to the medial geniculate body. And from there, the optic radiation will start up. And it will go into the pericalcarine area where the primary visual cortex is. So this is a functional MRI with visual cortex that you can actually see the part of the brain with which we are performing the visual function. And that part is connected to the orbit through this optic radiation and the lateral geniculate body, which are actually the relay points, through the optic tract, through the optic chiasm, through the optic nerves. And you can analyze it much better with the DTI and tractography. We perform it routinely in all the brain tumors because whenever there's a brain tumor, it distorts the normal anatomy. The normal landmarks are actually gone. And neurosurgeon needs to know where the different prominent eloquent tracts are. And for that, we perform DTI, perfusion, diffusion, and functional MRI. So these are the visual pathways in short: the orbits, the optic nerves here, the optic chiasm, optic tracts, and then getting into the lateral geniculate body, and this is the optic radiation going to the calcarine sulcus. So let's look at some of the pathologies of the optic nerve. Now, those pathologies here would be, let's see, cannot switch to, no, it's not going to give me. Okay, so here is something which we all know. This is actually a collection of CSF surrounding the optic nerves. You can see that in the bilateral intraorbital segments. And this is secondary to a pseudotumor cerebri. Up here, you can see a patient who has actually a huge pilocytic astrocytoma of the thalamus. And then he has these two bulky fusiform tumors of the optic nerves, and that's the optic pathway glioma. I unfortunately not able to play it because I chose the function of a laser pointer. So let me see if I can get out of it. I do not think I can do it without. Let me end the show, get back, and then see if I can come back without a pointer. So just bear with me for a single second.
Okay, sir.
Yeah. Okay. All right. So So let me try to, no, I think I'll need to display setting has to change, and that is much better. Okay, you can see my whole slide, correct?
Yes, sir.
Okay, excellent. So this is my little video here that I can play out, and that video shows in the axial plane, and it's in a loop that you can see there's a huge pilocytic astrocytoma at the hypothalamus, which actually infiltrates into bilateral basal ganglia. And then it continues on with in the orbital cavity as the optic. Now, the case below that is that of neuromyelitis optica, and you can see again, I think okay. And in here, you can see that there's the enhancing part of the optic nerve. You can see the optic chiasm, the optic nerve, the optic tracts are enhancing. And within the spinal cord, there is this expansile intramedullary hyperintense T2 long segment lesion. So that's typical of neuromyelitis optica. This one is, as we all know, it's a huge cellular mass with a supracellular extension, which has a big mass effect on the optic chiasm. And this causes the bitemporal hemianopsia. Yeah, it's very typical of pituitary macroadenoma. The one here is actually, you can see an astrocytoma in the temporooccipital region. Now, as I said earlier, we want to know what is its relationship with the optic pathways. And that is something which you can do by doing tractography. So you can actually perform the tractography, make it in the multiple planes, and then that was if you can see, that is the mass. And you can see that the optic tract actually is deviated, but it's not infiltrated by the mass. So there's a lot of things you can do with the modern imaging, but the fact remains that the more information you give the neurosurgeon, it's better for you. So now let's come to the real cranial nerves, which starts with the cranial nerve 3. And we can see that, let's look at the segments A and B into the third cranial nerve. So as I said, segment A and B, they're surrounded by brainstem parenchyma. They're not directly visualized, and the location of cranial nerve, like you can actually call it 3A, 3.A, and 3.B, and this is proposed by Ari. We don't do it in our usual practice, but that's just a suggestion. This makes a lot of sense. So let's go on further. That cranial nerve 3, which is an oculomotor nerve. So cranial nerve 3 is a motor nerve to almost all the intraorbital muscles. It includes the superior rectus, the medial rectus, inferior rectus, inferior oblique, and it also carries the parasympathetic innervation. So whenever there is a lesion of the third cranial nerve, the patient ends up having oculomotor ophthalmoplegia. So it's a very typical condition which every ophthalmologist is trained to diagnose clinically, and that is the downward and abducted globe. There is pupillary dilation. That's because of the sympathetic fibers. There is paralysis of accommodation, strabismus, and ptosis. Now, radiologically, we all know that aneurysm of posterior communicating artery can actually cause third nerve palsy and give rise to oculomotor ophthalmoplegia. And if you look at the anatomy, that the posterior communicating artery actually rides on top, just superior to the third cranial nerve. At the same time, if there is ankle herniation due to increased intracranial pressure, that also compresses upon the cranial nerve 3 from the side, and that can give rise to oculomotor ophthalmoplegia. And also downward shift of brainstem can stretch third cranial nerve. So let's look at the third cranial nerve. This is actually in normal anatomy, but this is a Fiesta sequence. So Fiesta sequence is excellent to look at the cisternal segment of the cranial nerves, and we actually make it a part of every cranial nerve protocol. And if you look at the different parts here, you can see that is the third cranial nerve getting out from the cerebral peduncles, and in the center is the basilar artery, which is dividing into the PCA bilaterally within the interpedunculaar system. And the most common pathology, of course, and that, of course, this small guy is the SCA. So the third cranial nerve is actually between the superior cerebellar artery and posterior cerebral artery. And that's where it becomes susceptible to any processes of the posterior communicating artery. Now let's look at a lesion, and I'm actually going to show you most of the lesion as schwannomas, because because it outlines the cranial nerve, and B, because we do not have all the time in the world to show all the pathologies of different cranial nerves. But let's look at the schwannoma of the third cranial nerve. And then this is a patient which presented with right upper extremity weakness and mass effect on the cerebral peduncles. The nerve's kind of origin is indeterminate, but if you look at the position getting into the interpeduncular system and in the medial surface of the middle cranial fossa, this actually is bound to be a third cranial nerve schwannoma. So looking at the anatomy a little bit, this is the ICA, that is the PCA, the posterior cerebral artery, that's a PCOM. And we are actually at the superior part of the interpeduncular system. So as we go down on this Fiesta sequences, which is a heavily T2 weighted 3D sequence, now we come to the PCA. And as we go downwards a little bit, now we can see the origin of the third cranial nerve. And this is the basilar artery. This is the third cranial nerve on the other side. Again, going down, we can actually visualize both the third cranial nerves. And going further down, we can now see superior cerebellar artery taking off. So in reality, if you just look at that, let's say this is the sagittal plane here. Within the sagittal plane, this is, let's say, a 22-year-old presenting with diplopia. And what you can see here is this is the third cranial nerve, and that was actually the third cranial. You can trace it. So right there, you can see the third cranial nerve, and let me show you the relationship. So that's the third cranial nerve within the substance of the brainstem. This is the cisternal portion, and the cisternal portion is right underneath the PCA and the right above the SCA, and that is why an aneurysm of posterior communicating artery right there will affect it very badly. And this is the intracavernous segment, and here through the superior orbital fissure, it enters the orbital cavity and divides to supply all the different muscles. And if you look at it in different planes, you can see the relationship in the coronal plane very well, how it is in between the two nerves. It's coming at you. And now, let me start from the beginning. And this in the axial plane, this is actually pathology to show you. That actually is the schwannoma of the third cranial nerve. And here is the course of the normal third cranial nerve, which we have outlined. This was one of our RSNA presentations. So that's the nucleus of third cranial nerve, right behind the interpeduncular system. And then the cranial nerve third takes up. This is cisternal portion. This is the cavernous portion, and this is within the orbital cavity, which is the extracranial portion. Okay, and that shows that relationship beautifully. Going on to the fourth cranial nerve, the trochlear nerve. Now that is actually the smallest cranial nerve. It's very difficult to image with MR, and if it is normal, sometimes you don't even see that. It's a pure motor nerve, the superior oblique muscle. It supplies only one muscle, and that's why there are very few fibers, and that's why it's very small. And this is what will be the clinical presentation. But looking at the fourth cranial nerve, the trochlear nerve, that is the third, which we see, and this is the fourth. Now that arises from a nucleus on both the sides of the aqueduct of Sylvius within the midbrain. And It is the only cranial nerve that arises from the posterior surface or dorsal surface of the brainstem. Not only it comes through, but it's the only cranial nerve that crosses over. So even though it is small, there are some unique features about the fourth cranial nerve. In that, it arises from the dorsal surface of the brainstem and it crosses over. All other cranial nerves, they actually supply the same side that it arises from. But the trochlear nerve supplies the contralateral side, which is so unique about it. And then in the ambient cistern, it courses around the perimesencephalic cistern. Again, it courses just like the third cranial nerve in between the superior cerebellar artery and the posterior cerebral artery, and then enters into the cavernous portion on the side. And from the cavernous portion through the supraorbital fissure, this is the extracranial portion, which actually courses medially because it is supplying the superior oblique muscle. So that is the trajectory of the fourth cranial nerve. And now we looked at, this is the superior colliculus, this is inferior colliculus. This is known as the superior medullary velum. And the fourth cranial nerve kind of arises and then comes out. So let's look at the anatomy of the fourth cranial nerve. So I showed you the nucleus of third cranial nerve. This is the nucleus of fourth, but then the nerve that comes through is coming from the contralateral side. So it kind of wraps around the midbrain and then it enters the cavernous sinus. And in the axial plane, it is very close to the nucleus of third cranial nerve. This is how it looks like, 3 and 4. And again, it shows the different parts of the fourth cranial nerve going through into the brain. And this is actually at the level of superior colliculus, because superior colliculus is associated with the orbit and the visual function. Inferior colliculus is associated with the auditory function. So you can see it going through the ambient cistern, prepontine cistern, into the orbital fissure, and this actually shows the relationship of the third and fourth cranial nerve with the vascular structures. Looking at MRI and normal anatomy, you can see the fourth cranial nerve with the very wispy, small, thread-like structures in the ambient cistern. And that's the superior cerebellar artery right there. And this tiny oblong structure, which is intensely enhancing along the expected course of the fourth cranial nerve, is a schwannoma of the fourth cranial nerve. Patient presenting with diplopia, as you would expect in a superior oblique muscle palsy. Okay, now we come to the big guy, and this is the trigeminal nerve, the fifth cranial nerve. This is a whole topic and a chapter by itself, so we'll try to cover it as much as we can. But then it has 3 parts, as we all know. It's divided into V1, V2, and V3. V1 is the ophthalmic nerve, which actually causes the sensory innervation of the scalp, the forehead, the nose, the globe. The maxillary nerve actually is responsible for the sensory innervation of the cheek and the upper teeth. And it actually has, the other nerves are the greater and lesser palatine nerves, so it goes into the palate and hard and soft palate. V3 is the mandibular nerve, and you can see them. Actually, this is the cisternal course of fifth cranial nerve. Within the mactal scale, this is the trigeminal ganglion. That's V1, V2, and V3 kind of drops down directly through foramen ovale into the skull base to supply the muscles of mastication, including pterygoids and masseter, and then it goes down, and then it gives the nerve to the mylohyoid muscle and anterior of digastric muscle, and then the sensory muscle. Sensory part of that nerve actually gets into the mandible, and then it actually becomes the inferior alveolar nerve, the lingual nerve, and then outside it becomes the auricular. It communicates with the auriculotemporal nerves. So it's a big cranial nerve, and that allows us very well to visualize the segment C and D of the cranial nerve, which is the cisternal segment and the cisternal cave segment. So it is surrounded by CSF, and that's why we see it very well. It's very well visualized on thin section T2 weighted images. And these are different vendors named like Fiesta, SSFP, T2 Space, but it means the same thing, that we are able to see the fifth cranial nerve. And you can see that in all its glory, the cisternal portion arising from the side of the pons, not the ventral surface, not the dorsal surface, but from the side of the pons. And it enters the Meckel's cave here, where it terminates into the trigeminal ganglion. So if you look at the nucleus part of the fifth cranial nerve, it has actually 4 nuclei. It's a big nerve. 3 of them are motor, 1 is sensory, and extends from midbrain to the upper cervical cord. It's kind of long segment nucleus. It's just not flat, rounded nucleus. The mesencephalic, the main sensory nucleus, which is huge, and then there's a motor nucleus, which is kind of a tiny compared to the sensory nucleus, because the main motor nerve of the maxillofacial structure is 7th cranial nerve, and the main sensory nerve is the 5th cranial nerve. So looking at some of the pathologies of the 5th cranial nerve, when it emerges from the lateral pons, on the left side, you can see there is a normal CSF and Meckel's cave, but on the right side, you see a filling defect, which is expansile, which is mildly hyper intense through the brain parenchyma, but not as bright as the CSF. And it's fusiform dilation. It actually starts from the cisternal portion, gets into the Meckel's cave, and on post-contrast imaging, there is very intense post-contrast enhancement, which also extends into the lateral surface of the cavernous sinus. And this is the normal cavernous sinus on the left. You can see the intracavernous ICA coursing up. But in here, the intracavernous ICA is pushed medially because of the huge mass arising from the lateral surface of the cavernous sinus. And if you look at the normal anatomy, this is the cisternal portion of both the cranial nerve 5, and that is this is a prepontine cistern. That's a Meckel's cave you're looking at, and then on the right side, it doesn't look quite the same it doesn't look a cord-like linear structure, but a rounded structure on the right side. And that is because you are actually looking at a schwannoma. And on post-contrast imaging, you can see intense enhancement of the same rounded soft tissue. Going down, that schwannoma extends through the lateral border of the cavernous sinus. And you can see a huge mass along the lateral border of the right cavernous sinus, which is the schwannoma of the 5th cranial nerve, or trigeminal nerve. And then it can also have cystic degeneration as you go more lower down, because larger the tumor, more are the chances of tumor necrosis. And then on T2 axial imaging, one of the sequelae of a trigeminal nerve schwannoma is seen very well. You can see denervation atrophy of the pterygoid muscles here, of the masticator muscles here, just lateral to the mandibular ramus. That's because the 5th cranial nerve is kind of drying up in some ways, and muscles of mastication are atrophied. Again, another patient with left facial numbness, and you can see a large mass which actually distorts and compresses the brainstem, and then you can see a cord-like structure extending into the Meckel's cave, and this is very typical of a 5th cranial nerve schwannoma. Again, we come to the next segment, which is, we can see very well, which is actually the interdural segment. And generally, the interdural segment is associated with venous blood. And which cranial nerve is better positioned to show you the relationship within the interdural segment? And that's the 5th cranial nerve. So if you look at it, this is a heavily T2-weighted coronal image, and we are at the level of the pituitary fossa. You can see the sella turcica, that's optic chiasm, and here is the cavernous sinus on your right. And within the lateral wall of the right cavernous sinus, you can see various structures. The one on the top, that is the third cranial nerve. So this is the segment cranial nerve 3.E, because this is segment E. And then going down, you have cranial nerve 4. So that is the cranial nerve 4E. And going down, that's the cranial nerve 6, which is just lateral to the intracavernous part of the ICA. And this one is not within the wall of cavernous sinus. It is a free-floating cranial nerve within and surrounded on all the sides by venous blood, which is flowing within the cavernous sinus. And then going down, you can see this huge segment of cranial nerve V1 and V2. And V3 is not seen because from the trigeminal ganglion, it actually definitely and straight down, drops down into the foramen ovale and exits the skull. So that actually is the cranial nerve V3, that one, and which is not part of the cavernous sinus. And then cis with contrast again is a very good sequence to look at the cranial nerve because they kind of stand out. Let's look at the different divisions of the cranial nerve 5. We are still within the cranial nerve 5, which is V1 division or ophthalmic nerve. Now that courses into the lateral part of the cavernous sinus. Here we see very well, it is just below cranial nerve 4, just above V2. It exits the skull through the superior orbital fissure, and then within the orbital cavity, it divides into the lacrimal, the frontal, the nasociliary nerves, continues on as supraorbital nerve on the superior margin of the orbit, and then exits through the supraorbital foramen to supply the sensory part of the forehead. So that is the sensory part. And then we come to the next part of the cranial nerve that we would like to admire and see and analyze, which is the foraminal part. This is a foramen through which a cranial nerve will exit the cranial cavity and become extracranial. And if you look at that, that again can be surrounded by venous blood, some capillaries and fat, and of course bone. It's not very well visualized on the traditional T2-weighted images because of the susceptibility. But if you look at the contrast enhanced T2-weighted images, then you can see them very well. So let's look at the axial heavily T2-weighted imaging, and the arrow points towards the foramen rotundum, and that is the V2 segment going into the pterygopalatine fossa, and that you can see very well in the coronal plane right there. And that is when the second cranial, the V2 or the second division of fifth cranial nerve drops down into the pterygopalatine fossa. And from there, actually, it goes into, so let's say if you look at its course, it courses into the intracavernous portion. Underneath the V1, it exits the skull base through foramen rotundum right there, and then it actually drops into the pterygopalatine fossa. And that, you can see that these are the different segments of the orbital floor. So this is the foramen rotundum, this is the pterygopalatine fossa, this is the infraorbital fissure, and then it actually, you can see that in the orbital floor right there. And that's because it's a schwannoma, you can see it much better, of course. V3 is the third division of the fifth cranial nerve, also known as mandibular nerve. It does not pass through the cavernous sinus. It actually drops directly down from the trigeminal ganglion into an expanded foramen ovale. You can compare the foramen ovale of the right and the left side, and you can see that this one is expanded, but very smoothly expanded. And that's because it has a large, intensely enhancing soft tissue mass going through that. And you can see that in different parts. The motor route, of course, will bypass the trigeminal ganglion. The masseter nerve actually, it starts off at the skull base. So this is the pterygoid muscle. You can see it, that's the temporalis muscle. So you can compare the left and right temporalis muscle and see the atrophy of the right temporalis muscle. Then you can look at the pterygoid muscle. And that's the lateral pterygoid, that's the medial pterygoid, and that's the masseter muscle. And you can see that there's a relatively diminution in size of all these muscles, and that's because of the lesion of the fifth cranial nerve. Now, this is because of the proximal lesion of the fifth cranial nerve. On the right side is a case with an injury to the distal part of the fifth cranial nerve, and then the muscles of masseter are, of course, affected, but on top, you can see that the antebelly of digastric is also thinned out as compared to the other side. And this is due to the distal V3 injury. And now let's look at the extracranial portion of the fifth cranial nerve. And you can see that very well. And the fifth cranial nerve is the only nerve, and especially V3 is the only cranial nerve that you can visualize on a normal routine MRI study, even when it is normal. When there is a tumor, when there is a lesion, when there is abnormal enhancement, you can always see it. But even when it is normal, V3 is the only cranial nerve that you can see and admire and trace very well. And these are the V3 segments bilaterally dropping down into the middle skull base through the foramen of ovale. And looking at the coronal plane, you can see that it's kind of going down between the pterygoid muscles right there through the foramen of ovale. You can trace it downwards. And that's, of course, is a Maxwell's case. So let's look at a case of perineural spread. And it is like everything is enhancing. You can see that. You can see the enhancement in the foramen of rotundum. It's V2. You can see it in the lateral wall of the cavernous sinus. You can actually see the enhancement of even the crust, which is leading into the tentorium. So you can see the dural margin of incisura even lighting up. And that's, again, the third cranial nerve. That is intraorbital extension. And you can see this is the V3, which is kind of lighting up. And so you can see the perineural enhancement along the V2, in the second cranial nerve. You can see it along the third cranial nerve. You can see it along the fifth cranial nerve. And squamous cell carcinoma and adenocarcinoma are two passes which actually like the perineural spread. I had a whole talk on perineural spread at the Chandigarh conference last year. And there you can see in detail how the perineural spread, it kind of creeps along the different branches of the fifth and seventh cranial nerve and enters the cranial cavity in the retrograde fashion. So now here you can see that there is involvement of bilateral trigeminal ganglion. You can see that in the Maxwell's cave kind of lighting up. You can see the intracavernous portion kind of lighting up. You can see that here is the V1 segment and it is the V2 segment in the rotunda. So all different cranial nerves lighting up in the perineural spread. So finally, the fifth cranial nerve is over. We can now start off with the abducent nerve, the sixth cranial nerve. That's a pure motor nerve. That innervates the lateral rectus muscle only and nothing else. And this gives rise to a sixth nerve palsy, which is known as squint. It kind of gives rise to complex neuropathy, but let's trace its anatomic orientation. So within the nucleus, it is actually just in front of what is known as the facial colliculus in the floor of the fourth ventricle. The facial colliculus is formed due to the fasciculi of the seventh cranial nerve, which kind of wraps around this area, but the nucleus of sixth cranial nerve is right in front of the facial colliculus. But the course of the B segment or the intraparenchymal fasciculi, they course anteriorly. And then it, of course, emerges onto the ventral surface of the brain. And when it emerges on the ventral surface of pons, the lower pons, it's the only cranial nerve that goes superiorly instead of going flat or inferiorly after it emerges. So it courses superiorly within the prepontine cistern and enters a structure known as Dorello's canal, which is actually an infolding of the dura, and through that it enters the cavernous sinus, and that makes it the interdural segment. So within the cavernous sinus, as I said earlier, it is actually free floating within the cavernous sinus, surrounded on all the sides by the venous blood of the sinus. It, it is not along the wall. And then it actually enters the orbital cavity through a ring. It's a fibrous ring, which is known as the annulus of Zinn. To that ring are actually attached all the extraocular musculature. And then it crosses from medial to lateral to innervate all the different muscles of the orbit. So you can see that it's kind of coursing through, it comes straight on, then it ascends in the cisternal segment. This is where it enters the Dorello's canal. That's the cavernous segment, and that is the intraorbital segment. And you can see in the axial plane that here is the nucleus of sixth cranial nerve just in front of the facial colliculus, and then it courses through the pons ventrally, emerges on the ventral surface, courses superiorly within the prepontine cistern, enters the Dorello's canal, which is a small dural infolding, enters the cavernous sinus, within the cavernous sinus, surrounded by on all the sides by the venous blood, and through the annulus of Zinn, actually it passes into the orbital cavity. And this actually, in a nutshell, is the course of the sixth cranial nerve. So you have the cisternal portion, the petroclaval portion, the cavernous portion, and the orbital portion of the sixth cranial nerve. And looking at, and why I was actually emphasizing on the location of the nucleus is that whenever there is a palsy, the lesion can be anywhere along the course of the cranial nerve. So you have to look at the nucleus, you have to look at the fasciculi, the cisternal segment, the dural cave, the interdural segment, the foraminal segment, and the extracranial segment, so that you can analyze that particular cranial nerve and come to a conclusion as to the site of the lesion. And many a times, we are actually, whenever the patient is referred to us by a neurologist and says sixth cranial palsy, we are so much focused on looking at the cisternal part of the cranial nerve that we forget to look at the nucleus. And this is exactly what is going on, that there is actually an area of restricted diffusion with diminished diffusion coefficient, hyperintense flare signal, and hyperintense T2 signal, which corresponds to the location of the nucleus of the sixth cranial nerve. So this is actually a brainstem infarct, which involves the cranial nerve 6 nucleus. And this is a young female who actually had surgery for 8th cranial nerve schwannoma. Then she had 6th nerve palsy. Again, looking at this intensely enhancing mass lesion, which is the schwannoma of the cisternal segment of the 6th cranial nerve. Going on to the facial nerve, or the 7th nerve. Finally, we are more than halfway through. The facial nerve is again a big nerve. It has 3 nuclei, out of which 1 is motor, 2 are sensory. It's predominantly a motor nerve, which supplies the muscles of facial expression. So whenever I'm speaking, all the muscles on my face and grimacing, all this is conveyed through the 7th cranial nerve. It also carries the parasympathetic supply to the lacrimal gland, the submandibular gland, and the sublingual gland. And it's also responsible for the sense of taste in the anterior two-thirds of the tongue. So let's look at its anatomy so that we can go forward. So this is, we are again at the level of the 4th ventricle, and then let's look at the nucleus of the 7th cranial nerve. So this is kind of the facial colliculus, that's the 6th nerve nucleus, and the 7th nerve nucleus is actually located just in front of the 6th nerve nucleus, and then the fiber tracts, or the segment B, that loops around the nucleus of 6th cranial nerve. and then it comes out from the side of the. So like the fifth cranial nerve, again, the fifth emerges from the side, the sixth emerges from the front or the ventral surface, seventh again emerges from the lateral surface of the brainstem. And then it is actually, you can also see it's the seventh cranial nerve, but at the same time, because different part. So that's the facial nerve. That is the nucleus. This is the abducent nucleus. That's the facial colliculus. And these two are the nucleus of the tractus solitarius and the superior salivary nucleus. So these two are the parasympathetic fibers. This makes the nerve of Rysberg. Then it emerges into the cisternal segment. So whenever it emerges into the cisternal segment, you can see that that is actually the cisternal segment of the seventh cranial nerve. This is the nervus intermedius. And that is actually just anterior to the vestibular cochlear nerve in the cisternal portion. So this is the CP angle cistern, and the anteriormost part is the seventh cranial nerve. And then from the cisternal portion, it actually will lead you to the canalicular portion. So this is the canalicular portion of the seventh cranial nerve, which is anterior to the vestibulocochlear nerve. And then let's look at some pathology of the canalicular segment. This is an intensely enhancing mass entering the IAC, and you can see that that goes all the way from the porus acousticus to the fundus of the IAC, but it does not enter the cochlear canal, and because that is actually the seventh cranial nerve. And then from the canalicular segment, the next segment is the labyrinthine segment. And this is through the facial nerve canal, which you can see very well on CT. But on MR, you can actually hallucinate the labyrinthine segment of the seventh cranial nerve. You can certainly see the genicular ganglion along the lateral margin. And from there, it gives off an anterior branch, which is the greater superficial petrosal nerve, and then bulk of it actually makes a hairpin bend and turns posteriorly to continue on as the tympanic segment of the seventh cranial nerve. So looking at the anatomy, some of the pathology of the labyrinthine segment. So this is, again, you can see that from the CP angle cisternal segment to the canalicular segment, to the labyrinthine segment, there is an enhancing mass at the genu of the geniculate fossa. So this is the genu of the seventh cranial nerve, and this is the anterior part, the greater superficial petrosal nerve, which goes along, actually it proceeds along the carotid canal, and then it combines with some of the sympathetic fibers to form the median nerve, which actually communicates with the pterygopalatine ganglion and the pterygopalatine fossa. It's a very interesting connection between the seventh and the fifth cranial nerve. Looking at this case on the left, this is a coronal CT reconstruction, and you can see that's a normal geniculate fossa, but at the same time, here is the expansion and erosion. And it's a kind of uniform expansion and asymmetrical enlargement of the labyrinthine segment of the seventh cranial nerve, which is probably due to the schwannoma. So now looking at the tympanic segment of the seventh cranial nerve, as we saw previously, that's the labyrinthine segment coming out, and here is the genicular ganglion, and the bulk of the seventh cranial nerve will continue posteriorly as the tympanic segment. And that tympanic segment, when it courses posteriorly, will go all the way down into the mastoid canal, and then it dives down into the stylomastoid foramen, and that makes it the descending segment of the seventh cranial nerve. So it emerges actually right behind the stylomastoid process, and in the stylomastoid foramen, so just behind the stylar process, and then it continues on into the parotid gland. But before it does that, it gives off branches to the stapedius muscle, and you can sometimes actually see the chorda tympani branch very well. And I see that much better on CT, where I can see that little canal, which actually emerges from the mastoid canal and goes into the temporal bone, into the mesotympanum. The chorda tympani, of course, is responsible for the sense of taste in the anterior two-thirds of the tongue. This is an MR image again, and you can see very well. This is actually the retromandibular vein, but you can see that right there actually is the motor segment of the seventh cranial nerve, and then what it does is that it courses just behind the retromandibular vein, and then it courses into the superficial lobe of the parotid gland, and some of the motor parts will continue on to the facial parts and supply the muscles of the facial expression. And now we come to the eighth cranial nerve, the vestibulocochlear nerve. The main function, of course, as we all know, it's all about hearing, and it's all about our relative position with relation to the gravitational force. So that's the vestibular part, and the hearing part is the cochlear part. So let's look at the anatomy here, and they again arise from the side of the brainstem. So it emerges from the lateral surface again. It courses to the pores acousticus. The anterior part is cranial nerve 7. The posterior part is the vestibulocochlear nerve. And then it actually supplies the cochlea and the vestibule. Now that's a very complex process. And I have this little MPEG, which we did for one of the presentations in RSNA. But if you look at the sense of hearing, let's look at the cochlear nerve and the vestibular nerve and how they play their part. So I'm going to click on this, and you should be able to see. So this actually is the organ of Cordy. That's modalus. That's a cochlear nerve. So when I'm actually talking to you, when I'm speaking to you, the whole thing is coursing through that. So let me try to do that again. Oh, it doesn't want to go back. I think we can. Okay, so let's start all over. That's the organ of Cordy. See very well here. From there, the hearing goes through the modalus, the cochlear nerve, and it goes to cochlear aperture. This is the cochlea, basal tongue, and then for equilibrium, the three semicircular canal do the job. This is cranial 7. This is the cochlear nerve, superior vestibular segment, inferior vestibular segment. That's the crista galli, which divides the two. Our famous 7-up, coke down, that's the crista galli. And here in that segment, you can see the 7, the cochlear, the SV1 and the V2, the superior and the inferior. And there you can see the vestibulocochlear nerve in all its glory. And that's, of course, the 7th cranial nerve, the facial nerve, and this is the vestibulocochlear nerve. Going forward, let's look at some of the schwannomas of the 8th cranial nerve, intensely enhancing intracranialicular part. And then this is a contrast enhanced T1-weighted images, of course, and then you can see that as the feeling defect in the parasagittal T2 weighted images, where you can see them very well within the ISC as a feeling defect. Now, as we all know that about 10% of the patients with acoustic tumor will present with acute hearing loss. And these are the patients that we actually analyze and we give them a pathology or not. But if you look at the real incidence, only 1% of the patient which present with acute hearing loss will have acoustic tumor. So 10% of the tumor will present with acute hearing loss. But if you go only by symptom, only 1% of the patient with acute hearing loss will have acoustic tumors. But the only way for them to know is to get an MRI of brain, and that's where we come into play. So this again is a patient presenting with acute hearing loss. And I hope I had somebody to ask whether, what is going on here. But this is a pre-contrast T1 weighted image, and you can see that the kind of hyper-intense T1 structure, which is probably hemorrhage. And you can see that both these images are without contrast, but they're still bright, and that's because of the hemorrhage in the cystic schwannoma due to degeneration. So that's not uncommon. And if it is acute presentation and not chronic, then the possibility of hemorrhage is quite likely. And that hemorrhage can be within a cystic mass, or it could be intralabyrinthine hemorrhage. So looking at an acoustic schwannoma, you can see that laterally going through the CP angular cistern into the canalicular segment, but there is also a cystic part, a cystic component of the mass very well. And the bigger the tumor, the more likely it is bound to be cystic. And you can see that the little graphic here, there's a cochlea now, and this is a vestibular 1 and 2. Here is the middle ear cavity with the stapedius. And the intralabyrinthine schwannoma, again, can be within the cochlea, within the vestibule. It could be transaortic, it could be transmodalar, it could be transmacular. Whenever you see something like a bright structure within cochlear vestibule, you have to rule out labyrinthitis and hemorrhage. Now let's look at some of the case. This is a post-contrast imaging. You can see them lighting up on post-contrast images, and that again is a case of labyrinthine schwannoma. Now, labyrinthine schwannoma again are treated conservatively. So the surgical treatment is actually reserved only for people with intractable dizziness, or you have transmacular or transmodalar or transaortic tumor. But if it is isolated cochlear or vestibular mass, it is left alone. Moving on to the 9th cranial now, the glossopharyngeal now. Now, glossopharyngeal now is kind of lower down. It is responsible for the sensation of taste in the posterior 1/3 of the tongue. It carries the afferent sensory fibers from the middle ear and pharynx, also the parasympathetic fibers to the parotid gland, and a motor fiber to the stylopharyngiosus muscle. So whenever there is a palsy of the glossopharyngeal nerve, you have a typical presentation. But anatomically, for the radiologist, we can actually see that this is a jugular foramen, that's a jugular ridge, and you can see that it divides the jugular foramen into the pars nervosa, which is anterior, and pars vascularis, which is more posterior. And in this cartoon, you can see very well that the 9th cranial nerve resides in the pars nervosa. So the only structure of any importance which is actually in the pars nervosa, which you see here, is the 9th cranial nerve, because the jugular vein and all the other cranial nerve, which is the 10th and 11th, are within the pars vascularis. If you look at the coronal plane and you can see this eagle beak, here is the hypoglossal canal underneath that, but superior and lateral to it is a jugular spine, and you can see a pars nervosa sitting right on top. Pars vascularis is much more lateral, much more expanded. And on the right side on post-contrast imaging, you can see this internal jugular vein. And in the anterior part, you can see the anterior petrosal vein. You can also see the carotid vein, the carotid artery. So if you look at that anatomically, and this heavily T2 weighted image, which is part of my cranial nerve protocol for all the different cranial nerves, you can see that from the lateral surface, and this is in the post-olivary sulcus. So this is the medullary olive. In the post-olivary sulcus, you have the 9th, 10th, 11th cranial nerves taking off. And they actually, 9th is a little higher than the 10th, but it's kind of pretty close by. So it's very difficult to separate it out from the 10th and 11th. But that complex you can see taking off from the lateral surface of the medulla and going towards the jugular foramen. On the right side, I have outlined, this is the jugular bulb, that's the jugular spine here, that is the carotid artery, and then you can see that is the 9th cranial nerve passing through the jugular foramen. So if you look at, again, the post-contrast CT scan, then here is a jugular vein, and this is the extraforaminal component, and you can see that position relatively. So this is actually the 9th, which is more anterior, arising from the pars nervosa. So the 9th cranial nerve will lie actually on the anteromedial surface of the internal jugular vein. The 10th and 11th will lie actually at the posterior part of the medial surface of the internal jugular vein. And then the 12th, of course, is much anterior. And that's actually seen with relation to the carotid artery and not the internal jugular vein. 10th cranial nerve is the vagus nerve, again, a very important and huge nerve. And if you look at it again, it's very difficult to separate it out from the 9th or 10th or 11th. So you can see it arising in the post-olivary sulcus from the lateral surface of the medulla. And then, again, I have the same slide to show you for the anatomic positioning. But within the skull base, it actually goes to the carotid space now. So it runs in the carotid sheath. It courses inferiorly between the internal jugular vein and the carotid artery. And that's why we know that whenever there is a glomus figale, it's going to cleave the jugular vein and internal carotid artery. So whenever there is actually in the extracranial segment, this is the white arrow points towards the vagus now, situated posterior, but in between the internal carotid artery and the internal jugular vein. And that gives rise, whenever there's a tumor, then the artery and vein will be separated out. And that is very characteristic of a vagal lesion. In the extracranial segment again. So, and then the vocal cord palsy, so that happens because of the recurrent laryngeal nerve, which is again a branch of the vagus nerve. And on MRI of brain or CT scan of brain, there is medialization, there is thickening of the area of epiglottic fold, there is asymmetric prominence of the piriform sinus, and then there is medialization of the vocal cord. That's how you diagnose that. And that happens separately from the right and the left nerve. So you can see here the position of the vagus nerve with relation to the arch of aorta. And then you can see the inferior vena cava going more posteriorly. You can see that the right vagus nerve comes only up to the level of the recurrent laryngeal nerve, basically takes off midway through. So the right vagal nerve, of course, comes down, but the recurrent laryngeal nerve actually takes off a little higher on. So it takes off just at the level of the right subclavian artery. That's why it is higher. But on the left side, again, it takes off all the way at the level of the left main bronchus. So this is very important in diagnosis of the vocal cord paralysis. So you can see here this graphic, and this is again a 66-year-old male, which had dissecting aneurysm. It is and left vocal cord palsy. Now, what's going on here is that the dissecting aneurysm is at this level, basically, and that is why what is going on is that it is actually taking along the left. It's compressing upon the left recurrent laryngeal nerve, and that is why the patient has ended up with the left vocal cord palsy. Again, another case. There is a vagal schwannoma in the infrahyoid carotid space. You can see that it cleaves the intrajugular vein and the carotid artery. Huge one, going longitudinally, because this is along the course of the vagus nerve within the carotid space. And this is the surgical image, and you can see how the fusiform dilation of the vagus nerve is showing up there. Again, looking at a vagal nerve schwannoma intracranially, it's in the lower part of the CP angle cistern, and that continues on towards the jugular foramen and not IAC. So you have to be very careful when looking at an IAC mass. Sometimes we confuse between a vestibular schwannoma and the vagal nerve schwannoma, but with careful consideration, you would be much better. Coming on to the accessory nerve or 11th cranial nerve, again, it's a motor nerve, and that supplies only two muscles, the sternocleidomastoid right there and the trapezius right in the back. And if you look at its course, again, it arises from the same place that we saw previously, but it actually travels along with the cranial nerve 9 and 10, and then it goes through the pars vascularis of the jugular foramen, and then it supplies actually the sternocleidomastoid and trapezius. And a pathology of 11th cranial nerve will result into, you can see the atrophy of the sternocleidomastoid on the left side, and also the trapezius muscle on the left side as compared to the right side. So if you want to look at a schwannoma of the accessory nerve, then you can see that as an enhancing mass, which actually is adjacent to the posterior border of the levator scapula. And levator scapula is deep to sternocleidomastoid. It's right there. That's the levator scapula. And you compare both the sides, and you realize that that huge mass is the schwannoma of the 11th cranial nerve. And why I'm saying that is that look at the trapezius muscle on the left as compared to the trapezius on the right. There is a denervation atrophy of the trapezius muscle on the right side because of this huge mass. And now we can actually diagnose that on CT that this is a schwannoma of the 11th cranial nerve because of the location that it is located just lateral to the levator scapula, and also because of the atrophy of the trapezius muscle. There you go. And then again, another case of denervation atrophy. You can see how the sternocleidomastoid and the trapezius muscles show atrophy. That's actually the normal size levator scapulae muscle. Coming to the last nerve, which is hypoglossal nerve, the 12th cranial nerve, a very important nerve. And that is the one which arises from the ventral surface of the brainstem. So it arises from the ventral surface. This is the 9, 10, 11 arising from the sides. And then the nucleus is, of course, around the aqueduct. And then the fasciculi course through the medulla and then emerge in the pre-olivary surface, not the post-olivary surface. So that's how you can differentiate them. And if you look at the axial imaging, you can see this is the fascicular part. Here are the two 12th cranial nerve or the hypoglossal nerves. This is the cisternal segment. And a mass of that, you can see there is actually enlargement of the hypoglossal canal. And you can see this lobulated mass, which is kind of anterolateral. So do not confuse this with a mass of the 9, 10, 11 now or jugular fossa, because compared to the other side, this is the jugular fossa, which would be right here. On the left side, it will be much more posterior, because on the right side, you can see that's the flow void of the internal carotid artery, and just next to it is the internal jugular vein posteriorly, and then the jugular foramen is a little anterior. So hypoglossal canal, again, if you look at the CT, the center is clivus, and just lateral to clivus, you see this very well corticated bony canal. That's the hypoglossal canal, which is actually medial to the jugular foramen. And in the coronal plane, this is the eagle beak sign, and this is the jugular tubercle, and below that is the hypoglossal now canal, while the jugular foramen is superior and lateral to it. Again, if you look at the extracranial segment of the hypoglossal now, and this is a post-contrast T1 coronal. I'm sorry, this is a pre-contrast T1 coronal, and you can see the fatty atrophy of the right side of the tongue, and that is because of the lesion of the hypoglossal nerve. So there's a hemiatrophy of the tongue on the right with fatty deposition, and that is because of a lesion of the hypoglossal nerve on that side. Again, you can see this is a huge mass at the skull base, but at the same time, you can see fatty atrophy of the tongue, and you can say, this is because of the hypoglossal nerve schwannoma. Right there. So we have seen basically all the seven segments of the cranial nerves. We have seen the nucleus, we have seen the fasciculi, we have seen the cisternal portion, we have seen the dural cave of every cranial nerve, we have seen the interdural segment, we have seen the foraminal segment, and then we have seen the extracranial segment of all the 12 cranial nerves today. And this is, what I would advise, that you analyze the cranial nerve by this different segment. And whenever there is a patient with a palsy of any of the cranial nerve, analyze everything from the nucleus to the end organ, and then you'll find the lesion somewhere. If you look at the cranial neuropathies, they are either reversible or irreversible. If they are irreversible, then they are likely to be neoplastic or congenital or sometimes miscellaneous. But if it is reversible, then they are probably autoimmune, there's infectious etiology, there could be some metabolic etiology, some vascular compression is responsible, or neoplasm in the adjacent tissue, which will causing mass effect on that cranial nerve. Then, of course, there are, idiopathic variations. So analyze the cranial nerve based on pathology, the history, the anatomy, the imaging techniques. Of course, I don't need to advise you for that, but as I said earlier, CT is better for skull base because you can look at the foramina much better. So if you're suspecting the foraminal location for some reason, go for CT. In almost all the cases, you're going to have both the CT and MRI ordered by the physician, and you'll get a good diagnosis. But CT is very good to look at the foramina. So in conclusion, the understanding of the anatomical course and end organ of the 12th cranial nerve, knowledge of variable appearance of pathologies, which I did not go over exquisitely. We can do it some other time. And the knowledge of the treatment option and the sequela will lead to accurate diagnosis, treatment planning, and evaluation of treatment response. So that's all I have. These are my two boys, and they are actually standing near the Wright Brother Memorial. This says the brother Wilbur and Orville. These are the two boys who are very close to each other. So thank you very much. I thank you for the opportunity. And I hope somebody's listening because I have no way of knowing whether somebody's online or not. Thanks a lot once more.
So everybody is
So that was Dr. Gaurang Shah, who took MRI of cranial nerves for us. An excellent talk and a really exhaustive talk. So I'm extremely thankful to Dr. Gaurang Shah and Dr. Abhishek Mahajan sir as well for those wonderful lectures for today's Prelude. So we've shared the link for the registration for the international edition, online edition of the MRI teaching course in the chat box. Also, the Sonobuzz 2024 is to be held in January at Sahara Star, Mumbai. We'll be sharing the link for this as well. So now let's move on to our quiz, which will be taken by Dr. Mitusha Verma. She's a consultant radiologist in PET-CT, CTMR at Nanavati Max Super Speciality Hospital. Her special interests are body imaging and radiology advances. She is a co-guide for postgraduate DNB radiology and biomed engineering students. Has presented in various national and international conferences, received many awards, including the Times Applaud Young Achiever Award in Healthcare 2022 and the Leading Young Radiologist and at the Radiology and Imaging Excellence Awards by ILETS 2021. A very young dynamic radiologist. We all know her very well. So Mitusha, over to you. There are two winners for the quiz, which Mitusha will explain in detail, and they'll be receiving free registration for the online conference.
Thank you,
Mitusha,
Gauri. Yeah. Thank you. So with this now, as Gauri explained, we'll have a short quiz with 10 questions. You have to answer them in the chat box. So just put your diagnosis in the chat box. The last two are the prize-winning questions, and the person who gives the correct answer first will get the prize. And the prize is a free registration to the upcoming complete international edition of MRI teaching course, which is spread over 5 days because of the exhaustive program which we could curate. So 28th, 29th October, 3rd, 4th, and 5th of November. The registration links, as Gauri mentioned, are there in the chat box. We request you to register for the same as well because it's going to be really helpful, especially for those who are practicing MRI, because we are going to cover everything in MRI and specifically pertaining to advances and recent techniques. We do have papers and posters options, and case of the day, prize winning case of the day quizzes, as well as contests will be there during the course. So with this, now let us start with the quiz, and I will get back with the details of the upcoming course in between. So this is going to be the first question on your screen, and you have to identify the diagnosis and put it in the chat box. So you have to identify the type of kinetics curve, which we also call as Cole's kinetics curve. So just put your answers in the chat box. So when we do this dynamic imaging, we get these kind of curves based on the signal intensity after contrast injection, and depending on whether the contrast uptake is early or late, we can get 3 types of curve. We also follow it up with what happens next, whether there is a washout or not. So I can see people coming up with type 2 and type 1 curve. So basically we see that it is quite quick in uptake. So it's a rapid initial uptake and followed by like a dip in the way it is enhancing. So basically this is type 3 curve. So why I have kept like this, because just to mention like at a point that they are not very ideal curve most of the time. So in your practical day-to-day practice, if you use these curves, you will see that when we are putting the ROIs, the curves are not typically down falling, which we call it as washout. It will be just a small dip. But when we see actual plateauing or persistent contrast enhancement, there will be no downfall in the contrast enhancement kinetics once the contrast pickup is there. So basically you have to see the morphologic features also, but this type of curve is type 3 curve kinetics. So rapid fill-in will be there, followed by persistent rise, that is type 1. Plateauing is type 2 and washout is type 3. Now the next question on your screen. So 50-year-old female who presented with increasing fatigue and speech difficulty. And these are the images, axial T2, T1, post-contrast. And few more images, diffusion, swan, and flare. Also, we have given you spectroscopy. So by the location and by seeing the characteristics on flare and swan on contrast, if you can come up with a diagnosis. So I can see, yes, so Dr. Shalini has given the correct answer specifically, which is oligodendrogliomas. So third most common gliomas for 2 to 5% of primary brain tumors, and tumors are mainly seen for middle age group adults. Location are mostly cortical, therefore they present with seizures. And by definition, now as we know, it is all molecular biology based. IDH mutation, either IDH1 or 2 should be there, and 1p19q co-deletion. That has to be there. The typical appearance which we saw on gradient or swan was because of the calcium creating blooming. And also the enhancement is not a very reliable tumor marker or grade marker, but it would be heterogeneous enhancement. Diffusion restriction is a marker of high cellularity. And in these tumors, there will not be the significant restricted diffusion. One sign which we should know and should revise is T2 flare mismatch. It's a highly specific radiogenomic signature for diffuse astrocytomas, which are IDH mutant and 1p19q non-co-deleted, as opposed to the other lower grade gliomas. And this has a specificity of almost 100% for identifying these higher grade astrocytomas. So that is one thing. Now coming to the next case, which is on your screen. This is a 60-year-old female with PR bleeding. And you see something which is involving the rectum and the anal canal. So somebody has come up with a diagnosis of melanoma, I think looking on the bright intensity on these images. But if you look carefully, it is still T2 weighted sequence and not T1. And I think Dr. Seema is correctly mentioning it as carcinoma of rectum, which has mucinous component. So the same patient came after surgery, and in 2023, that is a gap of 2 years post-op, and she had something like this, where you could see that there is obstruction into the vaginal tract, and therefore there is upstream all distension in the vaginal cavity. So this is CA rectum with mucinous component, and this is the recurrence of the same with same signal intensity. So these are the tumors which are quite aggressive. They are bright on T2 weighted images, and they may create even after short interval. Recurrence is a known phenomena. Here there is a recurrent mass lesion causing all obstructive features in the vaginal cavity. So mucinous adenocarcinoma of the rectum with vaginal metastasis. Now coming to the next case on your screen. This is something from prostate. If you can identify and put it some PIRADS category to this lesion. So cases are little basic types. It's for discussion, it's just for revision and for fun activity, because last 2 cases we'll have prizes as well. So PIRADS 3, 4, 5, I can see in the chat box. So this is something which is involving the inner zone of the prostate gland, hypointense on T2 with restricted diffusion and some enhancement. So based on the size of the lesion, which is more than 1.5 centimeters, I have not given the size, but roughly. So this is definitely neoplastic. So if you are not taking size consideration, PIRADS 4 is also correct. PIRADS 5 is also correct. So basically, we understand that the neoplastic process in the prostate is commonly seen in the peripheral zone rather than the inner zone. But if it is there in the inner zone, what are the characteristics which we should look for and which we should utilize to characterize them into PIRADS 4 and 5 categories? So one of the most important marker is non-circumscribed. This term which we should take care of. So it has to be a T2 hypointensity, which is non-circumscribed. So the margins of this lesion or this area are going to be very fuzzy. They are going to be blurry. So it's like an erased charcoal. That also is a term which has been utilized. So for transition zone, the first sequence which we look is T2. On T2 weighted images, we are looking for hypointensity. Like in this example, we had a hypointense area, but there are a few other hypointense areas as well. These have little bit of a circumscription to their margins, but this one is relatively ill-defined with some kind of non-circumscribed margins. And then we go for, straight away they ask us to go for diffusion and post-contrast dynamic evaluation. With early post-contrast enhancement and restricted diffusion, we can put it as PIRADS 4 or 5 category based on the size of lesion. So that was about this case. And now let's come on to the fifth quiz case, which is this one from breast. And we have one USG picture, MR pictures, something which is quite well defined, but at the same time, quite vascular. Any diagnosis to this case, which you think of? So most of you think that it is phylloides. It was quite vascular. The shape, if you see, it looks like more like something oval, like how we see the usual fibroadenomas. And this is not phylloides, but PASH, which is pseudoangiomatous stromal hyperplasia. It's a benign and relatively uncommon mesenchymal overgrowth. So even if the patient might not feel it for a while because these are soft lesions and they are going to be highly vascular. These are diagnoses of exclusion, but definitely the MRI feature of being highly vascular helps in the diagnosis. Now coming to the sixth case on your screen, here it is. 57-year-old gentleman with progressive bilateral facial nerve palsies over past few months. So what we are seeing here is that there is definite enhancement along the nerve roots, multiple nerve roots. So on the right, the trigeminal nerve root is enhancing. On the left here, the 7th, 8th nerve complex is enhancing. So cranial nerve thickening, cranial nerve enhancement in a 57-year-old gentleman. What do you think it can be? If any differentials you could put to it. So one is sarcoid. Other one, Dr. Seema mentions perineural spread. What else can that be? So I have few other now. CIDP is also one of the differentials for multiple cranial nerve enhancement. We have few more images. Now I think most of you will get the correct diagnosis. So this was the same patient who came after a few months. Now with this lesion. Now what do you think? Multiple cranial nerves and then a focal lesion. Yeah, so here I think Dr. Pragya Ghosh has answered lymphoma. So this is the case. So lymphoma is one of the differentials for multiple cranial nerves enhancement and thickening at the same time. We have seen almost 5 to 7 cases by now over a period of 2 to 3 years. And also we have published one case series like that. Now this focal lesion had a good spectrum also, which resemble what we are expecting for lymphoma, with a choline peak and a lipid lactate peak. So twin peak sign of lymphoma. Lymphomas are tumors which are by incidence relatively uncommon, but in your practice, I'm sure if you're getting brain tumors and focal lesions, we see them often. These are highly cellular masses, and primary as well as secondary CNS lymphomas are known. Primary lymphomas, they may be solitary or they may be multiple. By location, they are pericallosal. That location is very common. They are usually solid, therefore they are known to have homogeneous enhancement. But if the patient is immunocompromised, or if somebody has given steroid thinking that this is demyelination or something, the tumor morphology might change and you may get central areas of non-enhancement. Therefore, even the surgeons, they try to avoid, or even the physicians, they try to avoid giving steroid to these patients if lymphoma is one of the differentials, because not only in radiology, but even the histopath images and the characteristic change when the patient has received steroid in cases of lymphoma. And therefore, the patient might get a delayed diagnosis because of this steroid injections in between, or steroid injections. So this is the case which we had, the case series which we had published, multiple cranial nerves involvement as a presentation of primary CNS lymphoma. So now coming to the 7th case, and this is the case on your screen, set of images, MRI, and something going around the kidneys. So if you see carefully on the signal characteristics, you can get into the diagnosis also. Both the kidneys are having similar kind of changes. Any differential to this case? Yes, so one we got is liposarcoma, Dr. Seema with perirenal lipomatosis. So definitely the correct part of it is there is fat component along the perinephric area. Perinephric fat is abnormal. Angiomyolipoma is one of the differentials. So here this is bilateral liposarcomas, perirenal liposarcomas. So dirty fat, heterogeneous appearance, it's not only lipomatosis, but there is something else going on. And this is perinephric liposarcomas. So they are again rare tumors, but they are known, and also they may be bilateral. So in this case, the kidney was one of the kidneys, right kidney was ectopically in pelvis, but still it had that liposarcoma with it, and a smaller area of similar signal intensity along the left kidney. Now coming to the case number 8, and just to remind you, case number 9, case number 10, be quick to answer the correct answers as they are the prize winning questions. Case number 8 on your screen. Easy diagnosis, kind of a spotter only. So what do you think this is? Dermoid, but all of these are T2 weighted sequences. I don't think we can see fat confidently here. See the appearance. And I know all of you who are tuned in, they know the answers. If you just see the kind of morphology, what is the descriptive term which you're going to use for it? Something like small cystic areas, bunch of, we call it bunch of grapes. I'm giving you hints also. So a lot of differentials coming in. So this is that typical bunch of grape appearance which we see with the hydatiform mole or gestational trophoblastic disease, that appearance, and this was within the uterine cavity. Okay, so now I move to the case number 9, which is the prize winning case. And I know all of you are very good because I'm seeing the correct answers for the last 8 cases. So I hope that you get the correct answers to these 2 and be quick in putting in the chat box. So case number 9 here on the screen. What do you think? Just you can try to give the complete diagnosis in one sentence, or if you want to put it in few words, that's also is fine. So again, set of MRI images, and I think Dr. Shalini came up with liposarcoma of uterus. So post-contrast images, specifically ADC has been given. And this organ which we are pertaining to is uterus. Yes, that's correct. Anything else? Leiomyosarcoma, Dr. Harsha. Okay, I think we can give it to Dr. Harsha, as she answered it first, but Dr. M. Chandramouli is also correct with fibroids and sarcoma. Gauri, we can just consider Dr. Harsha K as the winner for this one. And this is uterus, which is bulky and has multiple fibroids, but one of them is showing sarcomatous features in the form of large area of necrosis and restricted diffusion. So multiple fibroids and with one leiomyosarcoma. Dr. Harsha, I would request if you could please share your email ID in the chat box. Now the last question for today, and again, this is a prize-winning question, easy one. So just relax and answer it quickly. Yeah, here on your screen. So what do you think this is? So MR images from pelvis, and we are seeing something abnormal in the prostate gland. What do you think this is? Just come up with the differentials. And same person can attempt it multiple times, so that's not an issue. So what do you think this large nodule which is there, it is arising from where, inner zone, where it is and what it is exactly? So I think we have got the answer, and this time we can give it to Dr. M. Chandramouli for exophytic hyperplasia. So this is a benign prostatic nodule only, but this is exophytic nodule, which has kind of come up and is around the peripheral zone now. It has all the features with no restricted diffusion, well circumscribed margins, not T2 hypointense to a greater extent, and correctly mentioned ectopic or exophytic BPH nodule. So thank you all for being there with us today for this Prelude session. And it was really nice to see all of you participating in the quiz. Congratulations to Dr. Harsha and Dr. M. Chandramouli. Dr. Harsha has already shared the email ID, and I request Dr. Chandramouli also to please share the email IDs and phone numbers. And both of you get free registration to the upcoming MRI teaching course, International Edition 5-day conference. We have 2 more Prelude sessions. One is on 17th, one is on 22nd October. We are going to share the links. The links are the same actually, but again, we'll post on various social media platforms. And again, we'll have quiz sessions at the end of these 2-day Prelude as well, and prizes to be won. Please do participate in Prelude. They are just, registration is compulsory, but it is not charged. And we have speakers like Dr. Manjari Dige, Dr. Alok Jaju, Dr. Raj Kedar. They'll be talking about MRI in renal masses, MRI in pediatric brain tumors, and MRI in evaluation of placental pathologies. Do register for the complete course, which is 5-day thing, 28th, 29th October, 3rd, 4th, 5th November. Already shared the links in the chat box for registration, or else you can also visit Indian Radiologist webpage and you get links for all these courses coming up. So all these are going to be great speakers with huge amount of experience, and they have agreed to be a part of this course. Most of them are going to be live, or even if they are sharing recorded session due to differences in time zone, they are going to be live for Q&A sessions. We have Dr. Scott Flam, who is going to take a lot about cardiac MRIs, at least 3 to 4 topics he's going to cover. Dr. Manohar Shroff, sir, and then we have all these speakers from Mayo Clinic team who are going to take us through all advances in MRI. One day will be completely from Mayo Clinic. One day we have complete program under Dr. Dushyant Sahani, sir, and that will be from University of Washington. So it's going to be a good experience for all of us. Please do participate and register. upcoming Prelude sessions on 17th and 22nd of October. Also, please do join us for the same. Congratulations, Dr. Harsha and Dr. Chandramouli. And also, this is about Sonobuzz 2024. Registrations are on, and you can visit Indian Radiologist webpage and register for the same. This is going to be on site. It's already a popular event, and this is going to be in Mumbai, January. Other dates are 5th to 7th Jan, and registrations are on. Thank you all. And with this, I think we can end today's Prelude session.